És akkor most Tunyogi Csaba.
And now, Mr. Csaba Tunyogi Miklos, Csaba Miklos Tunyogi, will give his presentation.
Nagyon szépen köszönöm a megtisztelő felkérést. Megpróbálunk egyből.
Thank you very much. Why don't we just start the last but one presentation, and thank you for the audience for sticking with us. Now, speaking about myself, for over 12 years, I've only been working with spinal deformities, and I've seen about 1,200 children. And I would like to focus on patients with muscle problems and cases which do not involve bone fusion. So typically I could say that what happens is we have about 200 operations of scoliosis. That's my performance a year. And about 10% of that are people with muscle diseases. That's about 20 cases a year. And that's about 10 to 15 SMA kids. We have more and more Duchenne, 3 to 5 Duchenne cases. I have not seen too many CMT patients, maybe not more than 5 in the past 15 years. Once again, I'm speaking about children operated with their spines, right? So I'm talking in a comprehensive manner and from the perspective of a surgeon, because when you see any muscle deformity, it could be lordosis, hyperkyphosis, scoliosis, any combination of those three. You don't have typical ways that these conditions present themselves, but this hyperlordotic pelvic thrust or dip to one side is common, but there are no typical forms. The primary group is about 80%. We have neuromuscular in the secondary scoliosis group. But what's important is that we're not only thinking about the spine, but also the relationship between the spine and the pelvis. So we're talking about these people become functional tetraplegic, which means these people will have to move around with all four extremities, because it's not how they look, it's how they function. Now, you have some of the forms that these situations present themselves, and we have congenital children with congenital conditions. But let me show you the major difference in terms of the deformity of somebody that is idiopathic as compared to somebody who is neuromuscular. And what our main job is to set the pelvis into its right position. And of course, the classification is diverse. It's varied, and you have a whole range of etiologies defined by the Scoliosis Society, and that's what we use to base our indications on. Now, spine deformities develop in different rates in these groups of patients. Somebody with DMD, Duchenne muscular dystrophia, they have 90%, and if they have that disease, then it will be progressive. It will not be stopped ever. With SMA, it's only 67% who have scoliosis. In my experience, is that type 1 and type 2, once they are beyond 20% and their curve is progressive, then that spine will collapse over time unless you operate on them. SMA1, SMA2 will have to be operated on. Now, type 3 is relatively more benign, and there is more room for conservative treatment. Now, if we talk about neurogenous curves as compared to AIS, the progression is completely different than in the case of neuromuscular cases. These children completely collapse if they don't get a brace or a corset. It could be 60 to 80% within a year or two. Sometimes we have 50 degrees of deterioration in half a year. So we have to monitor these kids. And the reason why you have to operate on these children is that this procedure, this course of the disease will not stop as the bones mature with puberty. It will continue as they become adults. So we try to use braces and orthoses at a very early age on, because the curves are very big already at a young age.
És hát teljesen más jellegű.
And when your hip is out of balance, then it causes and involves all sorts of types of deformities along the spine and all the way to the neck. And of course, when you talk about scoliosis situations among neuromuscular patients, there are up to 30% secondary conditions, complications that come with the scoliosis. Now, in idiopathic, patients are not operated on under 50%, 50 degrees. In the case of neuromuscular situations, we have to act much faster. In the case of idiopathic operations, we try to fix as short a section of the spine as possible. At the same time, in the case of neuromuscular diseases, that's not an option, because whatever we leave free, we not have enough musculature to balance the situation. My objective is not to create a completely straight spine. My objective is to create a balanced enough spine so that patients who are able to sit can sit as straight up as possible. Now, many people say that if you have 10 to 20% degrees in change with an SMA type 2 person in terms of average progression, that you have to operate on. Now, I think that there is a subgroup of patients who are able to walk, and then it is worth waiting a little bit more. But once you have rigid scoliosis, you will not be able to correct them with operation. This is a typical neuromuscular progression, and by age 6, you see an almost 80-degree scoliosis, and of course, it's way too high for correction with a brace, with a corset. So basically, if you ask me when it is a good idea to use a corset, I would say, well, anything I can temporarily correct just by moving it around manually, it's a good idea to use a corset. But once I cannot reset the spine manually, it's usually not a solution any longer. Now, let's talk about conservative treatments. And corsets are still a bone of contention. Still, many people debate whether it's good or not good. And people say that if you have a mobile spine, then you have to you should use it. It's worth using, but then you should use it as long as possible to win as much time as possible, because spontaneous fusion might happen still at a time when the spine is straight enough. So then operations can be pushed out in time. You want to postpone their series of operations. Now, that is the idea, to keep these children in a corset. Even if it doesn't help too much, we can slow down their progression, and we can maintain an acceptable degree of scoliosis for several years. So what we're monitoring is the maturity of the bone system under 10 years of age. We're not applying any bone fusion. Of course, there are various indicators that we monitor. There are systems that allow the children to grow, so we do not apply a fusion, but there are basically operations to stretch given sections of the spine. Now we can do that, operations with Majek as an external machine, basically, for stretching a section of the spine, and you don't need to use narcosis. Above age 12, 13, 14 is the ideal time when scoliosis operations make sense with fusion. Age 16 is way too late because of puberty setting in by that time. Now, this is a summary about how many more problems we have with children with neuromuscular conditions. They have more bleeding. The vascular system is much poorer, and also their bones are much softer because of immobilizing porosis. Sclerotic bone does not typically bleed. Children with neuromuscular problems bleed twice as much, while their body weight is much smaller, and that's a bigger challenge for anyone operating on them.
And this is where you can see how often we have complications in patients. Roughly, the average is 20% where we have complications after the operation. This is a summary table to show you what options we have to use surgery in the case of spines, still growing spines. This scale is from the US. There are three main options. One is based on distraction. Practically, the spine is stretched. The second one is when you fix it. You do not screw it down, but you let the endpoints slide, and you fix it. It's called a sliding system, Sheila technology. We do not use it in children with neuromuscular dystrophy at all. Again, it's a hot topic. The last one is the compression-based method, which is the only method not based on fusion. And it's getting increasingly popular in the US, and it means you are pulling in a band to correct adolescent patients, but it has a very narrow indication window when this can be done when it's feasible, but then you have a flexible and not rigid spine and torso, which is very promising in the long term. Let me now talk about the distraction-based procedure. We are trying to do it with a minimum invasive. We are trying to practically pull, stretch their spines apart. If there were systems available for pediatric systems, we have very low number of cases, so companies manufacturing these tools are not very keen on developing and placing on market child-size equipment. So what we do is to cover. It's the old Harrington type procedure. We leave a connector inside with which we can annually stretch and pull the spine, and we hold the child's hand from the age of 6, and every other 8 months we distract the spine by 2 centimeters. And the dollar sign correction, this is something you can use very much. The reason why I'm not very keen on doing it on both sides bilaterally is because if you push it to the convex, it will touch the bone membrane, and so bigger children over 50 kilograms are much more likely to break this thin rod because it's actually just is a very thin stick. These dollar sign corrections are very popular. If we talk about a non-fusion that is without ossification, so if you use screws and bolts, what you see is that these loosens, and that will result in the patient experiencing severe pain. So most of the time you stop at the lumbar stage, and you can see that the bone is soft, the bone quality is not adequate, and these have to be replaced every now and then. So revision operations involve not just with replacement, you need more screws, etc. So it's not just some minor operation. You need to replace these things. There are 70 children in Hungary who need adjustment operations annually. And this is what I've said. We are trying to avoid connecting systems on both sides that grows. And as the child grows, the fused side will be twisted, and it will give you more problems than what you have solved by including this. This carries a great risk for the patient and results in a great loss of blood. So I prefer supporting the concave side. Again, this is a child with SMA, and we were thinking hard how to do this practically. You press the straight rod against the spine, and this is how you straighten the spine, and you can correct the condition. And you can see as the time goes on, the pelvis is getting tilted, and it becomes disturbing and a problem for the child, and we go even down, increasingly downwards. And then we just keep reopening the lower wound, so the blood loss is kept at a minimum. And and after 3-4 days, you can release them back home. If the kyphosis is more extreme, then it's not enough to use one rod because this degree of kyphosis needs strengthening so that you can lift it out of position. I'm trying to make sure not to do anything on the concave side. If you start meddling there, it will start ossifying straight away, which means that you need to keep operating on the concave side. The rigid kyphosis, when you have small body weight, poor breathing, poor ventilation, children who have rigid bones already as a small child, no anesthesiast will undertake an operation on a child weighing 15 kilograms and has SMA. The only thing you can do is achieve some limited results to improve breathing by increasing the pulmonary surfaces. And if necessary, then we can move with the operations down towards the spinal, towards the pelvis, and even touch. And magic, if you have some time and patience. We already have 17 cases, which means we are gaining on experience. We were happy because it doesn't require a series of operations. It doesn't require anesthesia. So that was the initial happiness. But that works only if the spine is very soft, and every 6 weeks, we use this device, which is on loan. It comes from Germany. You need to organize it. You need to organize 17 children to undergo the procedure every 6 weeks to coordinate their growth. And if the child is not ready for another stretch, it just keeps working but will not be effective. And if you make a mistake, that costs 5 million forints, and if you do that twice, then you have wasted 10 million forints, which is an awful lot. So I'm not sure how to get back. This is a girl with SMA where we had a very soft spine, and it was easy to correct, very nicely corrected with the operation. And the problem is that the capacity of the rod runs out. These magic rods have a capacity of 6 to 8 centimeters, but not longer. But then here we have a more rigid deformity where the rod didn't even move. So now we are trying to offer fusion for her. She's 13, and that's that's the end of the story for her. So I think magic has its limitations, but it's possible. And what we are faced with in Hungary is I've seen thousands of cases of scoliosis. At least 15% is hopeless because they come to us too late. So I'm begging my colleagues, orthopedists, that if you meet a deformity like the omega spine on the right-hand side, you can't even access. It's nearly inoperable. It takes months to distract and stretch the spine to get it in a state where you can at least consider operation. That means that children stay with us for 3-4 months at the clinic to get them into a state, in a condition where an operation is an option, becomes an option. After halo traction, you can see that the curvy part at the top can be tracted, but on the right-hand side you can see you can try and pull these curves and put them in place. Again, this is not something you can. It's not an option because children are not just a piece of marble to carve. So what we can do is a metal distraction procedure. So once you have used a halo procedure, then we add some screws. And remember, we are talking about very soft bones here. We could correct this, but you are not supposed to do it with far too force because you tear the screws out of the bone. So you connect them, practically create a box, a frame, and you keep pulling these apart with great force, with a connecting rod, and then it's a fusion because we don't want to operate anymore. And obviously, it will give you more limited results, but you will still end up in a better situation than you were in when you started out. And you should always weigh the risk with the parents when to go for a 3-4 months hospital stay for limited results. So if they come to us early enough, then we can have much better results, and that's the point. And this is what we would like to achieve. This was, again, a boy with SMA. It took 2 months distraction and pulling to get him ready for operation. Fusion operations, just briefly, we go practically from their neck down to their pelvis. If you have a tilted pelvis, this is the way to go. These are major surgeries. We do operations like this 50, 60 hours. We have a huge waiting list, a very long waiting list, 3 hours. In Hungary, we have the longest waiting time, sadly. There are many patients. And again, another problem, anesthesia is a problem because we have very limited number of pediatric anesthesia specialists. And again, a hopeless case. Second image from the right, nearly 70 degrees scoliosis. And all we could do is support the spine from both sides. And I'm not sure in this case they are better off with the operation. It will not improve breathing functions that much than with or without operation. So there is a point in time where it's worth it and when it's not anymore. But it's very difficult to talk it over with parents when it may not be worth taking the risk of an operation. Again, here's a one-sided, and here you can see that the spine has been straightened out using the distraction method, but the entire chest is collapsing and the child is wasting away practically. I don't want to go into detail. How does correction technique look? Practically, children with ambulation undergo the same technique, same operation technique, and the principles we have had the same principles that you pull the concave side and compress the convex side, and this has been the method to go, the way to go for decades now. The revolution, derotation, where the entire chest cavity can be turned with these very robust tools, when you use a straight rod using on the spine, and parents very often wonder what steps we take and how it looks. And on the concave side, we make sure it's arched. On convex, you leave it straight and then push it down. So that's the basic technique we can use, and this is what you can. So it's practically, we just switch the spine back as much as we can, back in position. We are using these rods in situ, bending rods. And how can we do this tilting, correct tilting? Obviously, if you need to work from bottom down, you need, and this requires quite some force. The operating nurse, the surgeon, it requires 2-3 people to push the pelvis back into position. So, and it's never an easy. It's an uphill struggle, really. Requires quite some force. And there are complications you need to remember.
Dolgoznak, annál több
Just to show you some examples, the biggest problem you're afraid of is a septic complication with neuromuscular problems. So you use all sorts of sponges and antibiotics and open wounds several times over. And then you need a plastic surgeon to fix the whole thing. And if you have just one complication a year, that blocks at least one operating room or treatment room for half a year, because it takes sometimes 3 months to actually treat the complications of any given individual. Thoracoplastics, not very often done. We had a lady who had Charcot. It was an aesthetic operation to make the person look better. This also happens with young children. There was a hyperlordosis for this young boy. A couple of ribs are removed. We don't only want to make them look better, but also we want to preserve their walking ability. We need to maintain or reset their balance, both sagittally and coronally. And we want to preserve their ability to walk. We have a double curve here, and then we have an SMA2 girl whose hyperlordosis and expressed pelvic tilt is what was our major challenge. And then you can see an excellent balance. She can sit up without any help, and she doesn't need to rely on her hands for support either. You don't want a straight spine. That's not what you want. What you want is a balanced body posture. And finally, if the spine is way too rotated for me to apply screws and bolts, then an escape route is to use universal clamps that for a time we did not like to use. I just refer to this as the shoestring method. There are situations when the rotation is so big that I would have to install screws from the belly side, from the stomach frontal side. We don't want to do that. Instead, we use cables and pull those. I like to use this method, but it's an escape route. And I don't want to waste any more of your time. Just the take-home message, I think these kids must be monitored continuously because their situation deteriorates very quickly. But there are a lot of parents who are afraid of the risks of an operation, and then they put it off and postpone it and wait, trying to get their braveness together for the operation. That's not the right way to do it. You have to operate on these children as soon as possible. Thank you for your attention.
Köszönjük szépen, és akkor most
Well, thank you very much, and we'll have a short coffee break, and then you will have the possibility to ask questions during the roundtable discussion after the coffee break. Thank you.